Thank you very much, Philippe. Good afternoon, everybody. I'm very delighted to see there are still so many people interested in pulmonary disease assessment with MRI. The learning of my presentation will be different MRI sequences used to assess pulmonary disease, then to appreciate when MRI will be of value in patients with pulmonary disease, and the focus is a little bit on breathe in, breathe out, and dyspnea. So you're probably aware that there are a lot of challenges with regard to the black hole of MRI. This is due to low proton density, which relates to low signal, the low signal to noise ratio, which is associated with a low T2 star, and also all the motion that's going on in the lung. So the solutions are actually multiple acquisitions, short effective echo times, breath hold techniques on one hand, or respiratory ECG gating. And there are more approaches now with regard to intrinsic gating, for example. So the other challenge is here that certainly the amount of protons and the amount of tissue related to spins and signal is related to the disease we are looking at. So we have so-called plus pathologies where we have infiltrates, tumors, effusion, and they come with a lot of spins, and we will have a pretty high signal. However, when we are looking for emphysema, for example, we will have even less structure, and we are going to have even less blood volume in the lung, and this will, again, reduce the signal intensity. There's a very nice series of publications and insights into imaging from 2012 where all the different sequences and their potential are presented. That's what we call the sequence buffet. We have T1, T2, true FISP sequences, fat-suppressed stir images, and so on. And then we move also to respiratory-gated T2, turbospin echo, as well as diffusion, and then contrast-enhanced sequences. Well, what do we need? For example, the basic buffet will just be non-enhanced T1, non-enhanced T2, with a half Fourier, then a true FISP, which we can acquire during dynamic breathing, non-suspended breathing, to look for abnormalities over the breathing cycle, as well as a fat-suppressed to look for edema, fluid, and infection. This can be completed by a blade, which will reduce our motion artifacts. And you can actually do this in 15 minutes. So it is practical. You can really do this in routine. If we are looking for tumors and masses, we will go for a T1 pre-contrast, a T2, the true FISP, the blade, and then we are looking for the tumors and the lymph nodes with the diffusion-weighted acquisition, as well as provide contrast or and then do a post-contrast fat-suppressed T1. And this will take you 20 minutes. For example, for PE, another important disease causing dyspnea, you can be very fast. You can have the single-shot true FISP to look for central pulmonary emboli without the use of contrast, so you can rule out central pulmonary embolism in 2 minutes. If you want to go further, you will do a contrast administration and you will acquire a perfusion scan, a contrast-enhanced MRI angiography, and then a post-contrast T1 weighted image. Then you have the complete diagnosis, and we have learned that the combination of MR angiography and perfusion in MR is as good as multi-detector CT angiography. And again, the whole package, 15 minutes. So this is just, because it's very important, the dynamic contrast enhanced MRI of, not of a tumor, but of pulmonary perfusion. So it's a time-resolved T1 weighted ultrafast gradient echo sequence. And you can then nicely generate these images where you can have a distribution of perfusion scan or map. You can then take this further and apply some pharmacokinetic modeling to it, as we also do for tumor perfusion. You can use this for the lung, and we can generate these maps of pulmonary blood flow, pulmonary blood volume, mean transit time, and time to peak. And with this, you can characterize the lung perfusion to a very high degree. So what is the effect of posture? Patient lying supine in the scanner. Certainly the blood volume is distributed along the gravity gradient, so we will have a much higher pulmonary blood volume in the posterior lung parts than in the middle and the anterior parts. And it's also very important that we take care of the respiratory level, because the respiratory level has a big influence on pulmonary blood flow and pulmonary blood volume. As you can see on these color-coded maps, from the inspiratory and the expiratory scan. In the expiratory scan, we have less air, more blood, so we will have much more signal, which will make it more easy to assess perfusion defects, for example. We did some studies where we quantified the perfusion dependence on the respiratory level with dynamic contrast enhanced perfusion and pharmacokinetic modeling. Comparing this with phase contrast flow measurements, you can nicely see that the pulmonary blood flow and the pulmonary arterial blood flow measured by the phase contrast techniques nicely correlate, so that pulmonary blood flow goes up in expiration. And it's very important to be aware of this when you are looking at such scans or perform such measurements. It's another work where we were looking at the blood flow and compared free breathing with prospective ECG gating, free breathing with retrospective ECG gating, and expiratory breath hold imaging using ECG gating. And when you look at the flow, for example, the flow is higher in expiration and than free breathing. But when you perform such measurements in free breathing, actually it will probably most reasonably represent the physiologic condition of our patients, or of us as humans anyway. So here are the flow measurements, and you see that expiration has a significant effect. Contrast enhancement might be a challenge, so that's why a lot of groups have tried to develop techniques for measurements and visualization of perfusion and ventilation without the use of contrast agents. So this is one of these techniques. It's called Fourier decomposition, and it will nicely demonstrate a perfusion-weighted readout. As you can see here, this is a comparison with a contrast-enhanced MR perfusion. This is SPECT perfusion in the same animal. And this is the ventilation, the lung window setting from CT, the SPECT ventilation, as you can see here, and the Fourier decomposition ventilation-weighted readout. You can see that without the use of intravenous or inhaled contrast, you can obtain these wonderful images. Well, you can go to a more sophisticated, more complex techniques. This is the use of hyperpolarized gases, for example, hyperpolarized xenon-129. These are works where they demonstrated the feasibility in humans as well as the high image quality. And you can take this further and make use of the different properties of xenon gas so that you can actually map out the gas phase. So this is hyperpolarized xenon within the alveolar space. This is a dissolved xenon, so xenon that has been taken up into the vasculature, the pulmonary veins, and then you can also generate a color overlay of these and look for match and mismatch of ventilation and perfusion. Coming back to acute pulmonary embolism, we are now moving towards the different diseases. This is what I mentioned before, the non-contrast free breathing SSFP sequence, where you can really in 2 minutes generate the diagnosis or the exclusion of central pulmonary embolism. And we are using this in clinical routine, especially when there are contraindications for CT, for example, in this pregnant woman here, where you can nicely see the embolism here, so it's already pretty far in the periphery with very good image quality. There's a nice study where they looked at the value of different MR sequences compared to CT angiography. And you can see here, you will obtain the best result if you bring together and combine the non-contrast enhanced SSFP sequence together with a perfusion and an MR angiography investigation. You come up to a specificity of 100% and very good predictive values, with the sensitivity still being less when compared to CT. Pulmonary arterial hypertension, you see these impressive differences between idiopathic and chronic thromboembolic pulmonary hypertension. You can see it on the MR angiography scan, but you can also nicely appreciate the differences on the MR perfusion scan, where you see the more peripheral perfusion defects in the idiopathic form, whereas you have more central and wedge-shaped perfusion defects in the chronic thromboembolic form. Another very easy approach for the assessment of the severity of pulmonary hypertension is actually the measurement of the mean transit time, because pulmonary arterial hypertension will lead to longer transit times, as well as in the arterial, as well as in the venous bed of the pulmonary vasculature. So this has been nicely done in this study, where they looked at the transit time and volumes, and you see that in pulmonary arterial hypertension, the transit time is especially increased in the arterial, but also on the venous side. Cystic fibrosis, that's what Philippe already alluded to. MR is there, implemented in pediatric lung disease. It is established. We can visualize the mucus, as you can see here, but we are also using the perfusion scan to see the perfusion defects due to hypoxic vasoconstriction. We can apply this also in very, very young children. We now have a study starting at 4 weeks after postnatal screening for cystic fibrosis, and all the children, the newborns who are suspicious for cystic fibrosis on screening will undergo non-contrast enhanced MR in the first year and contrast enhanced 1 year later. So these are work using the Fourier decomposition. So this is non-contrast enhanced MR in cystic fibrosis patients, and you see that you can very nicely show the defects with the Fourier decomposition compared to a dynamic contrast enhanced scan. So this led us to the application of the non-contrast in the first year of life. Again, pulmonary perfusion is also very important in COPD, because COPD will have ventilation defects due to bronchial obstruction, loss of structure, and this will then lead to perfusion defects, again due to the reflex of hypoxic vasoconstriction. You can nicely see the match of the large emphysematous areas up here and the perfusion defect on the MR examination. What is also important is to look for dynamic MR during breathing for COPD, and you will see certainly the effects of hyperinflation and air trapping, that the motion here at different landmarks within the COPD patient is much, much less than in a healthy subject. Newer approaches, quantitative approaches, are looking into T1 mapping with and without oxygen, which might be used as a surrogate for gas exchange. So far, it has nicely been demonstrated that this technique is reproducible. The clinical value has still to be determined. For example, oxygen-enhanced MR has been compared with quantitative CT here by the Kobe group in Japan, where you can nicely see the enhancement due to the paramagnetic properties of oxygen. When you apply room air and then you switch to 100% oxygen, you can nicely generate, again, a map of ventilation and perfusion. And they nicely found that the differences between smokers without COPD, mild and moderate COPD, can be mirrored by MR techniques using oxygen-enhanced MR in comparison to quantitative CT. To use a more complex approach, hyperpolarized helium-3 has been used to phenotype COPD. So this alludes to what Nicolas Vesselati also demonstrated, that we can look for destruction type, emphysema type, where we'll have less ventilation defects, only a moderate amount of ventilation defects. But when you look at this map here, this is the apparent diffusion coefficient that provides a measure for the size of the alveolar spaces and the peripheral airways. And this is highly increased in the emphysema destructive COPD type. Whereas in the airway type, we have many more wedge-shaped ventilation defects, but the ADC, so the measurement of the size of the alveolar space, is much less decreased. So MR can also be helpful to phenotype COPD. What is really exciting, if you have a tracer gas in MR, which you can follow dynamically, such as hyperpolarized helium-3, you can look for collateral ventilation. You can really map out in COPD patients ventilation defects with delayed alveolar filling. So these are maps which will actually demonstrate the delay time to signal onset in certain areas. And you see that these areas which you might have called ventilation defects are just very slowly filling alveolar areas. And this can be a good indication in COPD, but also in bronchiolitis obliterans, and it might also help the planning of therapeutic endoscopic treatment in COPD using valves and something similar. Again, hyperpolarized xenon, safety and tolerability have been proven. And you see the combination of contrast-enhanced perfusion and contrast-enhanced hyperpolarized xenon ventilation maps. And this is COPD. So you see the big difference on the perfusion side and on the ventilation side. Again, the clinical application, or let's say preclinical application, at least in patients, of the imaging of the gas phase and the vascular, the perfusion phase. So this again is xenon, and this is xenon using the alveolar size imaging, so we're measuring the size of the alveoli, and we nicely can compare this with quantitative CT. You see the emphysematous areas on the CT, and you nicely see the emphysematous areas measured by hyperpolarized xenon. And this here is the xenon readout, where we look at the amount of xenon which has actually reached the vasculature, the pulmonary veins, so demonstrating that there has been gas exchange in these areas. And not really surprisingly, it could be demonstrated that the areas which are destructed by emphysema don't have any gas exchange, or let's say gas uptake. And then there are correlation maps which nicely demonstrate that the different factors and modalities with regard to destruction measured by CT and MR and the functional readout of the oxygen uptake or xenon uptake have very, very high correlations. Lung cancer, this is just a clinical example. Patient who was referred for suspected pneumonia. Iodine contrast was contraindicated. We performed an MR scan and we diagnosed this large lung cancer with poststenotic pneumonia, as you can see here, together with all the mediastinal lymphadenopathy. Perfusion imaging in lung cancer. This is the lung cancer. This is the SSFP sequence. Dynamic contrast enhanced imaging showed lower perfusion within the tumor than in the normal parenchyma, and this is the non-contrast image using this Fourier decomposition technique. So we can also very nicely assess perfusion of pulmonary parenchyma and lung tumors without the use of contrast. So, summary of my talk. There's a standard protocol established. You can easily find it on Insights into Imaging, and this will provide you for a good start in this field. Perfusion is key to a lot of the protocols or the assessment of lung cancer, also the advanced assessment of pulmonary embolism, hypoxic vasoconstriction, cystic fibrosis. It's very important. We can do this. Normally, that's what I would recommend to you, using dynamic contrast-enhanced MR. Ventilation in a clinical setting should be evaluated indirectly by perfusion imaging, and only in dedicated cases or in special studies, direct visualization of ventilation should be applied. Respiratory level and motion is something that more or less comes for free. You just run one of your SSFP sequences during continuous breathing, and you have the information about motion of the diaphragm, hyperinflation, and so on. And certainly MRI of the lung is of clinical value in pulmonary embolism and pulmonary arterial hypertension, in cystic fibrosis and COPD, and in lung cancer. Thank you very much.